Welcome back. This is part 2 of on-field emergency management of athletic injuries, equipment removal, and spinal immobilization. And again, I am Todd Heffron. I would like to thank numerous people for their help with this project, and again reiterate the disclaimers that this presentation has been put together based on the best evidence that I can obtain, including position statements from specialty organizations. And again, this information should be used in conjunction with your current clinical guidelines. Part 1 of the presentation involved looking at the evidence and emerging standards of care for spinal immobilization. In Part 2, we will look at the actual on-field removal of athletic equipment. One thing to remember about equipment removal is the face mask obviously must be removed to gain access to the patient's airway. The problem comes in if you're trying to use a bag valve mask or BVM to ventilate the patient, the chin strap is going to prevent adequate seal to provide the ventilations. The problem comes in that if you remove the chin strap, the head becomes unstable within the helmet. Therefore, if the chin strap is removed, the entire helmet needs to be removed. So we'll start with the helmet. If you look at the anatomy of a helmet, obviously you have the outer shell. Internally, there's multiple pads. This can be of many different types. Really the only concerning thing from a medical standpoint is on older helmets, they have cheek pads, which the arrows are pointing to, which may need to be removed. Now with most modern helmets, the helmet can be removed without taking these pads out. The other thing is on the helmet there are several ports which allow the inflation and deflation of these pads within the helmet. Again, generally, while the cheek pads can be deflated if need be, there should be no need to do this from EMS personnel. Now, the first thing you must do in an on-field emergency is remove the face mask. The mask is generally attached to the helmet with 4 clips, and it's recommended removing all the clips to remove the face mask. In the past, it was taught to just remove the 2 lower clips and then to flip the face mask up, but many helmets, this is not an option. Now, generally, there are 2 types of attachments for the face mask. Historically, most helmets have used a screw system, as you can see on the left, and a newer system has come out, which is the quick release system, which we'll get into in a minute. The screw system is fairly straightforward. It can be removed with any sort of screwdriver. Generally recommended to use a power screwdriver, as this will keep the head more stable instead of the constant torquing with a manual screwdriver. The quick release clip has a variety of different tools that are available, not only from the manufacturer to release the clip, but anything that can fit within this small hole in the center of the clip can release it. This includes anything from a ballpoint pen to many things you would find on a multi-tool. Now, worse comes to worse, you ultimately can cut any of these clips directly through the plastic right over the face mask bar. This can be done with anything from a formal trainer's angel, which you see on the bottom right, to pruning shears, and you may even try it with a good pair of trauma shears. So the trainer starts, in this case, by removing the side clips and then using a screwdriver to remove the top clips. Once all 4 clips have been removed, the face mask easily pops off. The next step in helmet removal is to address the chin strap. This can be attached by several different things, including a fixed screw, as you can see on the bottom. Most commonly, historically, it's been a snap tie on the top left, and the newer models are starting to use a zip tie or speed flex type system. So with the snap release, it should just be a quick pull to snap off the chin strap. For the zip tie type release, you first must remove this tab at the very end of the zip tie. There's a little tab that can then be pressed to allow retraction of the zip tie, and the chin strap can be flipped up over the head. Again, remembering to try and prevent as much excess motion as possible, and that once the chin strap is removed, the helmet must be removed. So once the face mask and chin strap have been removed, you're now ready to remove the whole helmet. Obviously, maintaining inline stabilization throughout the removal process, remembering that the cheek pads can be removed or deflated if absolutely necessary, and always remember that once the helmet is removed, that the head will fall backward, hyperextending, and must be supported either with someone maintaining stabilization or by simply placing a rolled towel underneath the back of the head. So the first person is going to come in and maintain spinal stabilization of the head and the helmet. The second person comes in, removes the face mask and chin strap, and then either the second person or another rescuer can come with their hands from below into the helmet to stabilize the cervical spine from below. The first person can then separate the sides of the helmet and gently pull it off the athlete, and can then either hold the head up or provide a towel for stabilization. There are multiple brands of helmets, and even within each brand, there are multiple different types of helmets. If you can familiarize yourself with the helmets that are being used, either before the game or even before the season, it would be helpful in an emergency situation. Now we'll move on to shoulder pad removal. The first thing, obviously, is that the shoulder pads are generally going to be covered by a jersey. If the patient has breathing issues or is pulseless, just cut the jersey off. And that can be done in a T-shaped fashion, generally starting in the collar, cutting straight down to the feet, and then cutting out each side of the sleeves. If your ABCs are okay, you may attempt to bunch the jersey up around the neck for removal. Once the shoulder pads are exposed, there are several binding areas that need to be addressed. The first of these is the front tie. This can be a shoelace tie, as seen in the top left. There can be a solid binding material, as seen in the top center picture, or there is also a newer technology called the ripcord on the top right that we will talk about later. The second point that needs to be addressed are the side straps, and usually there are either one or two of these. They can be attached most commonly by a belt buckle type apparatus, although there are multiple different types of quicker release mechanisms, either the older T-binder type or newer technologies like the quick release buckle on the top right. One thing to note is that there are many different types of padding that may be either attached directly to the shoulder pads or that may be worn underneath the shoulder pads. Generally, these things do not need special attention for removal or are unvelcroed to remove, but need to be recognized so that they are not destroyed in the removal process. In addition to the adjunctive padding, there are multiple types of medical braces which may or may not be attached to the pads. Most of these also Velcro together and are easily removed, but are often much more expensive than even the shoulder pads themselves. So we'll now go through the entire preparation process of the shoulder pads. First, obviously, is the cutting off of the jersey, first from the collar to the bottom, and then through each sleeve. Next, the side bindings are addressed, in this case with the buckle type. It's a simple unbuckle on either side. Finally, the front binding is either cut if it's a shoelace material or attempted to cut if it's a solid binding material. The removal of the shoulder pads themselves is actually the most difficult procedure in this talk. There are two different techniques that are used, both the elevated torso and the levitation technique. Maintaining spinal immobilization and neutrality during these maneuvers is the most difficult step in this whole process. So the first and more common technique is the elevated torso technique. 4 people are needed for this, and don't hesitate to recruit bystanders to help elevate the shoulders off of the ground. Just remember that the goal is to elevate the torso a few inches off the ground to pull the shoulder pads out from underneath the athlete, not to sit him up to a sitting position. The technique for Mark, the steps for the elevated torso technique start with the first person controlling the head and stabilizing the cervical spine. A second person then straddles the patient, reaching through the pads to control the spine and head from below. The third and fourth people then go on either side of the athlete, reach under the pads, and lift the athlete's shoulders off the ground. The first person then removes the pads and helmet, if still in place, and places a cervical collar on the athlete. So again, your first person controls the head. The second person straddles the patient, controlling the neck from below. The third and fourth people lift the shoulders up. The first person then removes the shoulder pads and places a cervical collar. The second technique is the levitation technique. This takes a lot more people, usually 6 to 8, depending on how big the athlete is. The athlete's body is then raised straight up, allowing the shoulder pads to drop to the ground and be pulled out. The nice thing about this technique is that a long spine board can then be slid in from the feet at the same time, reducing the need to log roll the patient later. The steps for the levitation technique are a little more intuitive, but obviously require a lot more people. The helmet must be off of this technique, and the first person at the head of the athlete maintains spinal mobilization. The next 6 to 8 people reach under the athlete's body and lift him or her straight up. Another person then removes the shoulder pads and places the long spine board and or cervical collar. So again, person at the head of the patient maintains spinal mobilization. Patient is then lifted straight up off the ground. The long spine board is placed if need be, and the shoulder pads are removed. Similarly to the helmets, there are many different brands and types of shoulder pads that you should familiarize yourself with if possible before the game or before the season. One of the newer technologies that has come out is the ripcord from Riddell. This involves a wire that, when cut and pulled from the front, releases the back plate on the shoulder pads, allowing them to be pulled apart without the need to lift the athlete off the ground. While this is helpful in removing the shoulder pads without lifting the athlete up, the front binding must still be cut and the side straps must still be removed as usual. To remove the rear binding, the small tab over the ripcord must be cut in the front, and then the wire is pulled all the way out. So finally, in the real world, most of what we've talked about is going to be done simultaneously. You're going to start with preparing the helmet and the shoulder pads. You're going to then elevate and remove the shoulder pads and or helmet, and finally package the patient however your protocols dictate. The first person stabilizes the helmet and head to protect the spine. The second person comes, releases the clips or unscrews the clips to take the face mask off. The chin strap is then either unsnapped or unzipped, depending on the type. The shoulder pads are then prepped, first by exposing them by cutting the jersey in a T shape. The front binding is then cut, and the side straps are either unbuckled or removed by whatever method is best. The second person then straddles the patient, controlling the cervical spine from below. The patient is elevated, and the first person removes the helmet and shoulder pads and then places a cervical collar. For this, we will show the log rolling and full immobilization procedure. However, at this point, whatever your protocol dictates should be done in regards to spinal motion restriction. This can be anything from allowing the patient to self-extricate to full spinal precautions with the use of a long spine board as demonstrated. Make sure that the patient is sufficiently tied down because they will be mad as hell that they're not going to be able to get back in the game. Just a note on other sports that are outside the scope of this presentation as it stands, but you may encounter depending on events that you may be covering. Specifically, hockey and lacrosse have similar padding systems, if not more extensive padding systems than even football. So some final takeaways from these presentations. It is in everyone's best interest, from the athlete to the medical personnel treating the athlete, if the athlete's equipment can be removed before transport. Secondly, make sure you prepare ahead of time, preferably before a season, but at least before a game, and familiarize yourself with not only the medical team and available resources, but also the equipment. Obviously, the third point is communicate. Again, whether this is before the event or on the field, everyone is there for the same goal. Remember, in a pulseless athlete, this is unlikely a spinal cord issue. They need the equipment off as soon as possible, and they need an AED on them sooner than that. And finally, if the athlete is neurologically intact and cooperative, take your time. Preserve the equipment if at all possible, and even consider allowing the athlete to get up and get off the field themselves. Here's a list of references that helped me in putting this presentation together. Also, I would like to apologize for anybody that I may have stolen images from online. Thank you for your time. I hope this information has been helpful. Hopefully, you will have a chance to get out, see, familiarize yourself with equipment, and even practice taking equipment off prior to meeting on the field in an emergent situation.